Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. Hello, and welcome to another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke Elms, and I'm joined today by Pete Santoro. Thank you so much for joining us, Sor.
Thank you very much for having me.
Yeah, so we, as we start every episode, we appreciate you coming on, and we'd love to hear a little bit about who you are, where you come from, and how you got where you are.
Absolutely. So my name is Pete Santoro. I am a general surgeon, abdominal wall surgeon, and I work in the state of Delaware. I'm from Delaware. If nobody knows where that is, it is a little state on the East Coast, just south of like the Philadelphia area. So grew up here, born here, raised here, and went away for med school and then came back and did my residency at Christiana Hospital, which is the biggest healthcare system in the state of Delaware. And then I stayed in the area in practice. I went into private practice initially after training for 4 years, and then was recruited to basically sort of head up the robotics department at Christiana and start a hernia center. So I started working there in 2018, and that's where I've been since. And my focus as far as work is abdominal wall surgery, hernia surgery. About probably 90+% of my practice now is hernia surgery. I do a little bit of other general surgery stuff, lumps and bumps, gallbladders, that kind of stuff. But it's acute care. But the majority of what I do is hernia, and I sort of have that little niche in my practice that not a lot of other people in this area do, which is like sort of the complex ab wall reconstruction and dealing with that kind of stuff. And started doing those robotically in 2017, and have been doing it ever since. And sort of more and more of my practice every year is that. So it's what I really enjoy doing and what I've sort of focused on.
And you are in private practice, correct?
Nope, I am hospital employed.
Okay.
So I was in private practice for the first 4 years, and then joined the staff at Christiana, which is it's a big academic affiliated healthcare system in the state of Delaware, affiliated with Jefferson University in Philadelphia.
When as you've kind of made that transition, has there been any major changes to the way that your practice has run? Any changes in the stressors of the job, things like that, as you've went from a private model to an employed model?
There's definitely differences. It was a while ago now. It was 2018, so like feel like it's a whole lifetime ago. The world's totally different now than it was back then. There's definitely pluses and minuses to being in private practice. There's definitely pluses and minuses to being in an employed model. But either way, it's been really good to sort of, when I was in private practice, having senior partner, I was by far the youngest guy in my group, and I replaced a very senior surgeon he basically retired June 30th, and I started July 1st in the job. So right out of training, and so having senior partners that were able to mentor me a little bit initially was very helpful. When I started in private practice, I joined a general surgery group that basically had a focus on ab wall, and had a hernia center associated with it. And so right out of training, I was doing a lot of hernia surgery and abdominal wall reconstruction, which was only being done open back then. So had good mentors, for the first 4 years, which was, I think, really, really helpful as I sort of got into, practice and, adapted my techniques from open to more minimally invasive as those things sort of evolved.
Mm-hmm. That's one thing that you and I have in common. Whenever I first came out, I was doing almost all open. And for me, there was a little bit of a feeling. I was always a big believer, still am, that if you're doing something minimally invasive, with I would say with rare exception, I can't think of any currently, but being able to at least do the open version of that procedure in case you had to bail out or something is an extremely important skill to have. And so I felt I had initially trained like in residency and had all the plans to come out and do like lap TEPs, balloon dissector, whole 9 yards, and did a few of those. Was not super supported by my senior partner, who was very much still in an open kind of mindset. And so I naturally started to gravitate towards open. And during that time, it was really actually helpful to kind of get that senior mentorship on how to do the hernia repairs. Ironically, the way he did them is still something that I take a lot of my lessons from, and even after going through a bunch of different education and listening to all these super experts on inguinal hernias and things talk, there's still a lot about what I learned from him and through that kind of mentorship time. So I definitely know that that what you're saying, like you go through that and coming out, it's like so difficult, and you have this expectation of what practice is going to be and what you're going to do, and then sometimes the situation you end up in is so different that you kind of have to reset. But it seems like you've really kind of progressed in your career into the minimally invasive pretty heavily.
Yeah, it was actually it's a really interesting time. It was really fortunate for me that I started when I did, because it's sort of everything sort of in the world of like the more advanced and like modern hernia world these days was like just sort of becoming big right around that time. So like I started practice in 2014. So in the next 2 years, TAR had just been described 2 years before that, right? I mean, Yuri's paper just was published in 2012. I mean, they were doing that a little bit before, but it was just becoming mainstream. And at the same time, the IHC, the RSC, robotics and general surgery were just being created. And people like sort of developing like, how is this going to be adapted to the world of general surgery? And then just the field of robotics in general was sort of just happening. And people, when I was in training, like we were doing like occasional gallbladders, occasional inguinals, but there was no one doing general surgical cases, particularly complex cases, in my area. And so it was just fortunate that, at the time that I was coming out, and for everybody, for people similar in my similar situation, that we had all of that sort of whirlwind of stuff happening at the same time. So, as I started, I was just doing, inguinals, gallbladders occasionally, robotic, and was doing all ventral work I was doing was all done open, because I didn't really have a lot of belief in laparoscopic ventral hernia repair. Without defect closure, you saw so many recurrences after those operations, and so I wasn't going to do it that way because I didn't really believe in it. And so as time sort of went on, people started reporting how they were doing robotic ventral. I sort of thought that was pretty interesting. Like 2015, 2016, I went up and watched Yusuf Kudsi do a day of ventral hernias on the robot. I think it was, I'm pretty sure it was on the SI. Yeah, it definitely was back then in 2016. And then I started doing robotic ventrals. Preperitoneal, started out just sort of wanting to get into that because it just seemed like a good way to use the robot, a good use of the robot, and definitely like good for patients, beneficial for patients. And so that's what I started doing. And then after that, it was sort of all in, I'm going to do everything on the robot. And then 2017, and at the same time, I was doing a lot of open ab wall reconstruction. That was a big part of our practice in the private practice that I was in initially. So had a lot of experience doing, open ab wall. And so sort of adapted, the preperitoneal techniques and the tissue planes and everything that we knew from open ab wall, which was, posterior, TAR, transverse abdominis release operations. And 2017 was able to do a robotic TAR for my first time. I had Igor come and proctor me for my first case, and he mentored
Yeah.
me for that. And then after that, it was off and running, with robotic ab wall. And I still do a lot of open, when it needs to be done. But
Sure.
a significant part of my practice is robotic abdominal wall reconstruction, which I feel very, very fortunate to be able to do. Just feel like I was sort of in the right place at the right time to be able to do that.
Yeah, definitely. I mean, definitely on the early part of the adoption of that technique for sure. I mean, I came much later. It's funny. You mentioned you still do some open. What we're finding is the more that you do the robotic abdominal wall recon, the more people view you as like the abdominal wall recon person, or at least one of the
Absolutely.
people. And so then you start seeing more and more complexity. And so like the more
Yeah, you
abdominal
get
wall
everything.
recon
Yeah.
we do, the more open we do, because then you have people show up that you're like, well, this, is just not a candidate for a robotic approach.
There's
And so
definitely
like,
cases where you see and you say, there's no chance this is going to be done robotically.
yeah, the more comfortable you get with a robotic abdominal recon, the more open you do, just because the cases that
Absolutely.
show
And
up.
the thing a huge thing that I noticed over, the first few years, and even now doing a robotic ab wall, is that I understand the anatomy so much better now than I did when I was, before I did it robotic. Like I was doing them first open, but particularly like the subxiphoid and the subdiaphragmatic
Yes,
dissection,
100%.
the dissection in the pelvis, the way that I do it now is totally different than the way I used to do it, and it's all been adapted because of the way that sort of I've been able to do it on the robot and see the different tissue planes, and I just wasn't aware of what I was even doing back then. Not that I was doing anything not safe. I think I was doing it safely. I just don't think I understood the anatomy back then nearly as
Oh,
good
yeah.
as I do now.
100%. Like in some of those cases, there are the techniques that are safe intuitively because that's how it's taught. And as long as you're like maintaining those techniques, you know that you're not going to like harm somebody. But there's a difference between knowing a technique and understanding the reason behind the technique. And that's what really, the robotics really did for me. In the OR, sometimes even doing like the robotic inguinal, so straightforward robotic inguinal, for me to see that anatomy like in real time doing it, because I mean, I did a few open preperitoneals before I was doing robotics, just because that's what the patient needed. But like you're like standing on your head, like trying to look down into the pelvis, like it's a really hard area to get to and see. And then you get comfortable with it robotically, and the next time you're in there in an open setting, you're like, oh, that's that. It's just, it really does feed to both sides, feed different levels of understanding and knowledge, because there is some benefit to having your hand in there and being like, oh, that's actually a lot thicker plane than I thought, or that's, the relation's a lot different than you can see robotically. But there's nothing like being able to visualize, just on a straightforward TAR, like those neurovascular bundles coming down, and exactly where you're cutting on the posterior sheath, and there's, it's a very interesting thing, and the visualization is so much better. And that's been one of the real hard parts for me, because we still have a surgery center, so occasionally I'll do a laparoscopic cholecystectomy, and the visualization for me is so much worse as far as like the cameras, still safe,
and like somebody holding the camera, and right, and it's not steady. It's like it's just a totally different experience. I mean, it's doable, obviously, but it feels like going back in time, right?
Yeah, because you sit there and you'll have the nurse, or the scrub that's holding it's like the drifter. And so pretty soon you're just like trying to operate out of the corner of the visual field. You're like, can we please center the camera? And they like look back, and then like 3 seconds later, the camera's staring off the abdominal wall again. You're like, can we center the camera? So it's a very funny. And the other thing about it though is that as we go more and more robotic, people do lose those skills. And so then your assistants, who aren't doing it on a daily basis anymore, all of a sudden, when you try to do it, it's harder. And it's an interesting conundrum, because we do have something that's so much better in a lot of ways. But then like some of the older techniques, as you lose those, you lose them. And so I understand people's concerns about, we still need to be learning the laparoscopic, but it's still one of the things about like an open cholecystectomy where you come into a point where you're going, well, what are we going to do to train people for open cholecystectomies that are hard? Doing an open chole during like a Whipple procedure, sure, but that doesn't necessarily replicate in a lot of times what you're getting into if you get into a conversion to an open chole. Nowadays, those aren't like easy cases. Those are the ones that are the hard ones.
They're the worst ones.
And doing something that you do infrequently in your hardest cases doesn't lend itself to safety just in general. So it's like you get to a point, it's like, what are we going to do? Just start randomly selecting people like, well, sorry, you're getting an open cholecystectomy because we need the educational
so we
value.
Can have some experience. Right, exactly.
Right. Yeah. It's such a weird thing. And so, I understand some of the concerns that are raised by people 100%, but it does raise concern.
Yeah. And even like you mentioned, the losing the skills, but with the junior residents coming up, some of them haven't even, they get to like their PGY 2 or 3 year, and they don't even know how to hold a camera because they never have, because everything that has been done has been robotic, which is not their fault. But they just don't know how to assist an operation, and because they just don't have experience, and that happens sometimes. So it is an interesting conundrum of how to train, the younger generation of residents, when they have now, we had 2 modalities. We had open and laparoscopic. Now they have 3 because it's open, robotic, and laparoscopic, and they are very different. Even though they're very similar, they're still very different. So it is something that everybody, I think, struggles through a little bit.
Yeah, it's interesting, and I think that I definitely don't have the answer, and I'm not sure there's a good answer. I think that there are definitely some transitions, but one thing about it is some of these residents are going to go out and graduate and go places where robotic access is not consistent, especially for stuff like acute care surgery. So being able to get through a hard laparoscopic chole, in an acute setting for cholecystitis is a skill that's probably still going to be necessary, but I just don't know how, I don't know how you standardize that. I know that our modeling and our simulation is so much better than it used to be. But, whenever I was coming up, it was pretty crude as far as just basic steps of the operation, as opposed to what you can actually get into in the actual OR.
Yeah. I mean, the simulators now are much, much better than back in the day with the SI and, with the just, task-based simulation, as opposed to now, like the SimNow 2.0 is very all case-based, or procedure-based simulation, and the simulation tasks that they do now the technology is amazing. So it's definitely better from a simulation standpoint, but from an education standpoint, the residents, I think they get an excellent experience. I mean, certainly depends on where they are, but at least in my place, they get a really good experience doing robotics. And but as that happens, you sort of you sacrifice one modality for the other, and they definitely get less laparoscopic. I would suspect that the average chief nowadays does a fraction of the lap choles that used to be done by as a chief, just because it's just not done anymore as much. But I think that's probably, I guess there are good and bad that go with it. But I mean, if you look at the good side, I mean, I think the operations are safer, the techniques are better, and the patients are going to do better. So
it's nice to see. It's nice to see data coming out now that supports my anecdotal experience, because I think that sometimes the data would come out and you're going, man, that really doesn't represent what I feel like I'm experiencing, and maybe I just have like an inherent observational bias of my own practice. I mean, that's always possible, especially when everybody talks about like tracking your outcomes, and it is so incredibly important. But the one thing that tracking your outcomes requires is time and resources, realistically. And so if you're in kind of like a run and gun type practice, if that's what the expectation is of you in your role, or you're at a model where that you're the sole provider and you've got to produce, or your family is going to feel it, those types of things, there are definitely pressures that make that harder. And it's kind of an interesting issue. I think that it'll be so much nicer when everything integrates so much easier, and hopefully we have the ability to integrate across all these EMRs and be able to track that data much more seamlessly. because right now there's a lot of data out there that's not captured, and that would probably provide some pretty good insight for some of the general surgeons that are not necessarily academically inclined, but are high volume doing the things we're talking
I mean,
about.
it would be great if we could have, huge pools of data. And I guess in some ways there are, with the HCQC and somehow Intuitive's data has to be somehow, maybe, I don't know, maybe it's not, but it would be great if you could have, access to significant amounts of data from them, de-identified or whatever. But yeah, I think generally speaking, like you're talking about, keeping track of your own data is really important. Uh, uh, follow up, for the, a huge hernia surgery and the field of abdominal wall surgery is, and I tell patients this all the time, because, one of the biggest questions you get asked when they come into the office is like, what about that mesh? Or I heard that, this is going to be, terribly painful or something. They always hear, these horror stories.
Sure.
And like one of my lines that I always tell patients is like, the field of abdominal wall surgery today is nothing like it was 15 years ago. It's totally changed.
Mm-hmm.
And not only, a lot of patients are, it's less nowadays, but patients are still come in, with issues about mesh. Like I heard, I saw that commercial on TV about that mesh. But not only the products that we use are different, some are similar, but very different. But the techniques that we use are totally different. And then just the fact that we have people that are, this is a specialty now, right? This is like something that people are dedicated to doing, and this is all they do. So we have very much highly specialized people that are doing this on a daily basis. So it's, it's a different field than it was 10, 15 years ago.
Yeah, it's interesting. I was listening to a lecture by Igor recently, and he was talking about the techniques he uses in the ETEP, right? And he was talking about all the different steps that he has added to his technique over the course of time, and how it actually takes him longer now to do it than it did earlier in his learning curve. And I think that's one of the dangers that we run into when we only track time as the metric for quality. Obviously, there are diminishing returns when time is excessive. There's diminishing returns when time is a marker for incompetence, obviously. But whenever you start adding steps to a procedure because of lessons learned from experience that may add time to the procedure, that's actually a net positive. And I think that it's an interesting thing that I 100% related when he was talking about that, just in straightforward general hernias. I've had a couple of recurrences where I reduced these big cord lipomas back, and I tucked them on top of the mesh like I was taught and like I'd done a bunch before. But then when I had a couple of them where these big cord lipomas, for whatever reason, got back under the mesh. Obviously, technical issue. And so, I changed a technique for that. So now I resect those. I don't just reduce them. I get those out of there so that they don't do that again. But that adds time to the case.
You know what I do with them? I think resecting is totally fine. But I don't know if I can't think of any one major case that I know that like the cord lipoma like scooted back under the mesh and recurred. But I was thinking at one point, this is years ago probably, that there's a good chance that could happen. So I started with the bigger ones. I just I find like the apex of the lipoma, and I put a figure of 8 vicryl and I sew it to the abdominal wall up high, not to the point of being able to disrupt the mesh laterally and inferiorly, but just the tagging stitch to just get it to scar there so that it doesn't fall down. I don't know. Hopefully it works.
It's it's something really funny the other day, because I send them all for path, because when I take stuff out, I send it with the vast majority of the time. So I took it out and I sent this one for path, and it was not an excessively large lipoma. And you have to make sure you're not getting back into your lymph node tissue and what plane you're in and all those things appropriately. But I took it out and I sent it, and it came back. And of course, usually when you're going through like I see that patient's path come back. I'm like, lipoma, click,
Click,
just like click
yeah.
through. And it goes, and this one goes, I read it down and I go to click and I'm like, wait, what did that just say? And I go back and it was, it had ectopic adrenal tissue in the tip of the lipoma.
Oh God.
Like in the very tip, like they were talking about like the everything, and they were like, yeah, and I was just like, that is really crazy. So
has that ever been described before? I've never heard
I think
of that.
so. Yeah, actually, I did. There's a few cases.
Well, I guess because theoretically, cord lipoma is an extension of Gerota's fascia fat, right? So it's somehow in that area of the adrenal. I don't
like
know.
an ectopic arrest of some developmental issue, but those are the things. The guy came back and I was like, "Did you have like blood pressure issues before or something?" Like that would be a surprise. But put somebody into an adrenal crisis during an inguinal hernia, and you're like, "What just happened?"
Or cure them of some kind of hyperadrenalism by taking out their cord lipoma. That would be really cool.
Yeah,
but the thing you mentioned about Igor just talking about ETEP, was it at the summit?
Yes, it was.
Yeah, I wasn't there, but I find it amazing with these guys, listening to them speak about operations that they basically invented. Or basically describe. They were the first person to describe it, like Yuri and Igor and these guys. It is just amazing to listen to them and their experience. But so that's one thing, just as an aside. But also the thing that you mentioned about time being a marker for in my practice, generally, I do value efficiency. I wouldn't call it like I'm not like sprinting towards the end, but I don't like to waste time in an operation. Like I'm not like a big, I like efficiency, but at the same time, using time as the measuring stick for good versus not good is not a good idea. So, a lot of posts, they talk about how long it takes to do this or that, or how fast I could do this or that, and that's probably not, that's not a great way to describe who's good and who's not.
Yeah, well, listen, I understand that if you're an incredibly skilled, incredibly efficient surgeon, and your times reflect that is absolutely, it's something that can be commended. I'm not suggesting that somebody that does a full critical view, very safe dissection, and could do a gallbladder in 10 minutes, good for you. Like, that is fantastic. I mean, there's people are going to benefit from your efficiency and your safety. But we've all seen people where they brag about how fast they are, and you go in the operating room where you see their complications, or you see when we were residents, you can see people that do stuff very quickly. And I always tell the residents, you don't gain speed in the operating room by cutting corners or moving faster. You gain it by being more efficient. Because I always tell them, I'm like, if your goal is to just tear stuff to get the dissection done, but you create a bunch of bleeding, in my experience, many times that adds time to my case. If I'm like chasing a whole bunch of bleeding. And so, I try to, and then also, for me personally, I've said it so many times on here, but I take my complications as such a reflection of me as a person. But whenever I have a complication where I say, did I go too fast? If I'd have slowed down, would I have been able to avoid that? Did I, those are questions that at least I always ask myself. First and foremost, when I see somebody come back, you can have I think people kind of fall into multiple categories, but some people are like going, what did they do? Because it can be very, very, it can be painful to be like, well, this is obviously my fault. Or, there are obviously patient factors involved too, no doubt. But in a lot of cases, I'm looking at it and I'm going like, okay, what could I have done different to prevent this? And if I ever feel like I was in a situation where I was being rushed, or I was not, if you ever feel like there's pressure to go faster, maybe it's like, well, anesthesia, they've got to go home, or the CRNA needs to be out of here by 3, and you're like, and so you feel these. And so I've always told the residents, I'm like, hurry, hurry, hurry until the timeout. And the moment that timeout starts, the case slows down. And and if you ever feel rushed, intentionally slow down. Because you're going to get yourself into trouble, and you're going to feel really bad if you realize that you were, in retrospect, that maybe you were rushing through something and there was a complication. And so I tell them, I'm like, listen, you get it by being more efficient. I think the frustration is when the lack of efficiency is not something you can control. When you're like, I need this piece of equipment, and they're like, oh, well, they're being processed downstairs. It's like, what are you talking about? Like, we didn't have an extra, like,
Yeah.
and so those are the things that can really just destroy your well-being throughout the course of your day when the efficiency lost is not even under your control.
Yeah, I always say with regards to that like as far as like burnout and things that make it difficult to do this job, I think that we are as surgeons extremely blessed and fortunate to do the job that we do. Um, the thing, maybe people get burnt out by just doing this. For me, I could do this all day, every day, as long as I had good outcomes and good, access to an operating room and patients that would allow me to operate on them. I think the thing that burns us out the most is that we rely on so many other people to do our job
Mm-hmm.
and rely on so many other things like going well to be able to get to the point of getting through our day.
Mm-hmm.
It is just a huge, I'm not sure what the right word is. It's just a difficult thing to have to, you can do all of your stuff right. Um, but there's so many other, factors throughout the day that need to line up so that things go smoothly. And sometimes they don't. And it can be, like you said, it can be very frustrating when it's not efficient like that.
Yeah.
Yeah.
It's so tough because at times it can be a little bit disheartening too, because whether it's true or not, when you're in the heat of the moment, sometimes it can feel like the people around you aren't as invested as you are. And maybe that's not true. Maybe they are. But at the time, you just sit there and maybe it's because I hold people to such a high standard, because I hold myself to such an incredibly high standard. And that just may not be fair. But sometimes it can be disheartening. You just look around and going like, does nobody care as much, and maybe they don't, maybe they do. I don't know. But it can be just, you're sitting there going, and it can be really lonely when things are not going smoothly or not going well. And you look around and you're like, do I have anybody else that's in this with me? Or am I just sitting here like the only person that really sees what's going on and is really trying? It can be tough.
Yeah, and I think that's sort of what sort of goes along with what I was just talking about is like, we as surgeons, take everything. I think everything we do very personally. Our outcomes, how our patients do, how we're seen as, how we're viewed as a surgeon, like how people see us. Or are we considered a good surgeon, not a good surgeon, slow, fast, skilled, no, whatever. But we take everything very, very personally, and there's lots of things throughout the day where some people don't take it like that. It's just a job,
Mm-hmm.
and it's just something to get through the day, and it's hard when your idea of what's good is different. It doesn't go along with everybody else's. It can be difficult. Um, but yeah, I mean, same. I'm very similar to you in that way. I take things very, very personally as far as like how my patients do, their outcomes. I do really poorly with complications.
Mm-hmm.
I take them very personally, um, and it's just something. It's something we all have to deal with, but it is really difficult.
Yeah, it can really, having a run of complications, it affects you so much more than at work too. And I think that's like one of the things that that's kind of hard to reconcile for me, is when I come to the realization that my work is bleeding over into the rest of my life.
Mm-hmm.
And not necessarily because it's affecting me. Like, I don't know, maybe I'm just like, maybe I'm a nihilist or something. I'm just like, I guess that's just the way it is. But I think it's when it affects my family, because I'll be like, because I come home after a really stressful week, and everybody's like, super excited for it to be Friday night. And one thing that my kids love, they absolutely love having like family movie night. And so
Mm-hmm.
they'll all pile up on the couch and make popcorn and do all that stuff. My son's 8, my daughter's 5. So we're usually watching, some kids movie, which is fine, with one side note caveat that annoys me about children, my children specifically. And here is, I watched the same movie 40 times. And by the time we watch it the 40th time, I'm like, you know what? This is actually a really good movie. And then my kids never want to watch it again. And so then I'm like, can we please go watch it? Like, well, it's family movie night 6 months later. I'm like, you know what we should do? We should watch Coco again or Encanto or something. And then they're like, no. And I'm like, come on, man. I watched it like 40 times with you. And now I'm feeling a little nostalgic and you won't even watch it with me now. It's like, I don't know.
Man, you gotta enjoy these moments. Cause I'll tell you, I 8, 9, 10, I think, maybe 7, 8, 9, 10, something like that. Those ages, those were that was my favorite time with the boys. I have 15-year-old twin boys, and so they're freshmen in high school now. And when they were like that age, it was the best. When I would come home, like they'd be so excited. They'd come running to the door. They'd come see me.
Yeah.
You know, they want to show me stuff from school. They want to go play out inside, do whatever. And now, they're high school, they're playing varsity baseball, they're, doing schoolwork, they're on their iPads doing whatever, and they, they're less interested in hanging out with dad. So that is the best time when they're like sub 10 years old.
Yeah, I'm finally coming into this period of time where like being dad's cool. Because usually I'll come walking in, my wife and I we may both be working during the day. And so we're rolling in at, 7, sometimes later at night. And the kids are usually either getting ready for bed or they're like sitting there having dinner with the nannies, made them dinner or something after school. And so I like walking the door. So it's when my wife is working, it's always the same thing. And it's funny because you kind of have to put a little bit of a case around your own feelings. But I walk in and they hear the door close and I hear mama, and I like walk in the door and they're like, oh, it's just dad.
Oh, yeah.
Okay, great. It's just dad. It's pretty funny, but I don't take it personal, but there is something really hilarious about it. And what the true testament of that is that my wife is like fantastic with our kids, and she's always game to like play their games, and she's always down to do the stuff they are. And sometimes I'm not. Sometimes my brain is just so locked up with fear of, is that person's, I hope that repair holds, or like you get done and you're just like, something just didn't feel good about that case. I hope they do okay, so I'm just in this like cycle in my own head. And it's not something that I'm like intentionally ignoring them. It's that I may be sitting there watching the movie and then my kids will be like, Dad, you're not even watching the movie. And I'll realize I'm just, completely zoned out. And so my wife is much better at that compartmentalization than I am. And so she has historically been much more with them also. And she works shift work. And so she gets the chance when she's not working,
just turn off.
To turn off and to drive them to school and to pick them up from school. And I'm always, on the job. So it's different.
Yeah, I think I would assume most of us are like that. I mean, there's definitely times when I'm here and, my wife will be like, what are you doing right now? Like, what are you thinking about? Because you're like, I'm totally not even like in, mentally in the same room as the rest of the family, because I'm thinking about some, like you said, is that patient going to come back in with some kind of problem? Or was that fascia closure, good enough? Is it going to break, it's going to break, whatever.
Yeah.
But yeah, it's all, I think we all have that. And it can be really difficult if something happens, like you were saying a little bit earlier, if you have some complication or some issue that happens at work, it's hard to not bring it home. And a lot of times I unfortunately do, and it can be very difficult to deal with because I'm like carrying that weight with me, and they can absolutely tell right away. Wife is like, what's the matter with you? I'll tell her, something happened, and whether or not I explain it to her is, it depends on what the thing is, but it's difficult. I mean, it's really hard to leave things at work and not bring those emotions into your house.
There's so many of us that are married or dating or their significant others within at least some level of the medical field. And I think that has like, it's like a double-edged sword, because we do have the ability to relate probably in a way that when I go tell my wife, a wound infection, my wife's no OB-GYN, she gets a wound infection, right? If she understands conceptually, she's had patients that have had that, those types of things. And so there's an understanding there. But on the flip side, it also can be kind of like an echo chamber. And sometimes you have to, it's nice sometimes to be around people that are not within the medical field to realize there's like life outside of this bubble, which at times can feel so toxic. And it's not that, and I think part of it's just the way I'm made, in that I don't feel the successes like at all. Like I don't ever feel whenever something goes well, my reaction is, well, of course it went well. It's supposed to go well. Right. I don't sit there and go like, hey, that one really tough case, they did really well. And that pat me on the back. And, and my office staff actually knows that. I had a patient, she had this very difficult vasculitis. They used to call it Wegener's. Now it's like a different name. And I only know anything really about it because I've been diagnosed with the precursor biomarkers for that. So that's kind of always just kind of like on the back of my mind, like hanging there, like it's going to go poorly at some point. But so she had this hard problem. She was diagnosed with it when her colon died from microvasculitis. Like she just woke up one day with pain and her colon was dead. She ended up with an ostomy that ended up getting reversed, and her reversal, she was in the hospital for like a month, and it was like a really rough recovery. And then she comes to me for this enormous colostomy site hernia, which was completely predictable because she had to be on high dose steroids to get her through the recovery the first times. And so all these other things. And so we end up taking her and get the case done. And I lost legitimately like 8 weeks of well-being, truthfully, just like every day, just being like, oh, when is that other shoe going to drop, And luckily she did very, very well, like surprisingly well for what I was expecting. And she got through it. And her and her family are like so kind and so thankful. And I'm in the room with them, and they're like telling me how much that like our work and my team's work and my work has really like impacted their lives in a positive way. And I don't understand why. I think it's me. I understand it's me, but like that, I'm almost like uncomfortable in those moments. Like I literally am just sitting there, like I'm being very gracious and stuff, but it's just like every time.
It's so funny to hear you. It's so funny to hear you talk about this, because it's just so familiar. It's just me also. So it's maybe it's, I don't know, maybe it's a personality thing. Maybe it's the way that you were brought up. Maybe it's I don't know what it is. I had to say, I mean, I'm very much the same way. I have I have a very difficult time accepting praise. Like I almost, it makes me uncomfortable in those situations. I don't know why. I've always been that way. I was a very successful athlete, high level. I never liked to talk about it. Never liked to, bring that stuff up. And then in this situation, as far as like the line of work that we're in, you have patients coming in telling you like, that you're the best. I came highly recommended by this and that, and they said you're the best. And I mean, all this stuff, and it's very difficult to listen to that and accept that and be comfortable with it, because I think one of the big reasons is like in the back of my mind, I'm thinking you're saying that, but something really bad could happen, and then you're going to be like very disappointed. That kind of thing. But also, like the one thing I wanted to just mention that you mentioned earlier is the thing about how it's hard to be not happy with, but let positives affect you in a positive way, but negatives affect you in such a negative way. Everything's just supposed to be everything's just supposed to be right, or end up the way that it is perfectly. But when it doesn't happen, that's a big problem. I don't know how you can combat that. It's something whenever something, a significant complication or some kind of like big problem happens or a bad outcome, and they have these, meetings, these, what do they call them? Like,
Peer reviews.
yeah, like peer review or
Yeah.
quality improvement reviews, these kinds of things. Uh, I've kind of joked with, not really joke, but said to one of our, some of our staff that run those, you know, it's amazing that we put such emphasis on the negatives, but like if I do something awesome, it just it's just it just happens, and
Yep.
it just goes out one door, out the way in the door, out the door. Just happens as that's the way it's supposed to end up.
Right.
Nobody says anything. It's just the way that it is. But if something really bad happens, that's a big problem. So
Sure.
I don't know.
Well,
I don't know what to do about that.
That's been one of my. You talk about is going back to something you said. You talk about being like a successful athlete. It's funny because I signed a national letter of intent, and I played a year of college basketball, and I tore both meniscus in my right knee in the off season, and was super, super anxious around performance anxiety surrounding my basketball career. And so whenever I tore my meniscus, it was going to set me back. And I probably, truthfully, I didn't get surgery on it. It just kind of let it scar down. It would have probably taken me out of the majority of the next season anyway. But I just took that as an opportunity to exit because I was just not in a good mental place about the whole process. And I was talking to one of my good friends who I've known since high school. And it was funny because he loves to call me out on like these weird like mental tics that I have about myself. And so I was talking to him, and I said, he said something about me playing college ball, and I was like, yeah, but I mean, like that was kind of a failure. And he was just like, what do you mean? And I was just like, yeah, I mean, I only played for like a year, and I didn't really feel like I ever performed at the level I was capable of during that season. And he was just like, and he goes, do you understand though that the number of people that get signed to a national letter of intent and play college ball, percentage of people that play even high school basketball is incredibly small? And I was just like, well, yeah, I mean, I guess I understand that, but it doesn't really, when you're in that kind of mindset, statistics don't apply to you. Like that's the biggest thing, like the statistics don't apply. And whenever I hear somebody give me like a compliment about an outcome, I heard in our physician book club that we host, one of my mentors was there, and he was talking, and he said, when people say that to him, the second they start complimenting him, the only thing in his head is a replay of all the cases that went poorly. And I think that's, and it almost, when you take your complications so personal, it almost feels like insincere or wrong or like unethical to feel good about a case that goes well when it's almost like you're dishonoring the person whose case didn't go well. And I know that sounds it's so weird to like articulate, but it's real. And I'm working on it, but I'm definitely not, I haven't conquered that.
No, I mean, I feel that. I hear that. I've definitely experienced that. Also, like, it's just, it's hard. I mean, the thing that you just know that, looming over everything is the potential for something really, really negative to happen. So, if you get really excited about something good happening, all of a sudden, is the complete opposite going to happen the next case or something like that?
Right.
So everything's a law of averages. Everything's going to come back to the middle. So it's not like you can have great forever. Right. It's going to, something bad, something bad's going to happen. So you just have to be ready for it.
My wife and I are the exact same way. Sometimes we'll be like, things will be really, really good. And sometimes when things are super good in my own family, like we'll have like this afternoon, like it's a beautiful Sunday afternoon, the kids are playing in the pool, we're just like hanging out, listening to music. Like it's so, like it is, by all intents and purposes, like the definition of happiness, right? And I will be out there, and it is, for some reason, it's like I have this continuum where it's like I'm so happy that all of a sudden I'm sad, and like I'll roll over into this like weird melancholy. And I was talking to my wife about it one time, and she goes, "Yeah, but doesn't it feel like things are like too good? Like you're like karma's going to correct at some point, and like this could all go away." And I'm like, yeah, it does. And I know, and that is totally like, that's like trauma speak. That's like PTSD. But the funny thing is people talk about PTSD, and we have like, you can have some things in your life that you can be like, hey, if you know that someone has this like thing in their past, you go, and they say they have PTSD, you're like, yeah, I get it. Right. So they have like a incredibly traumatic childhood with like abuse or neglect or something, or they have like our war veterans that have seen just horrific things. But we don't actually treat a lot of healthcare workers the same way. And, and I was talking to one of my friends who's a urologist, and we went and it's funny because I'm an all or nothing person. I recently started journaling, and all of a sudden I'm 50,000 words into an autobiography. But I was talking to him, and this is one of the stories I was writing about recently, but I was talking to him as we left Halloween Horror Nights a few years ago here at Universal. And so we exit this deal, and he was just like, what'd you think? And I was just like, wasn't that scary? And he's like, yeah, the stuff like movies and stuff, they don't scare me that much. And I said, honestly, the thing about it is I don't think anything can ever be as scary as that moment you're in the operating room and you realize the only thing between you and this person being dead, or between like this person being dead and alive, is you. And there's like that momentary, like, oh gosh, where I don't know how everybody else experiences it, but like my ears will ring. Like I will, there's like this weird, like temperature dysregulation that suddenly happens. And like, and it's all that adrenaline rush and everything that's happening, but there's nothing like that fear. And when you experience something like that, it can go and it can even turn out really well, but it sticks with you. And I mean, have these nightmares that'll happen over and over again. And they happen about things that happened years ago, and they'll just continue to happen. And we don't really give ourselves
like
enough
experiences.
Yeah. And
from years ago. Yeah.
Oh yeah. All the time. And I don't think that we give a lot of like we see horrible stuff, but we just kind of write it off as part of the job. And it devalues the human experience of what we're undergoing. And sometimes I think we need to really focus more on that.
Yeah, I mean, as you go through as a surgeon, it's hard to not depersonalize some things. I mean, you just, like you said, you see such bad stuff sometimes, and as far as like pathology or like trauma, but also just like the way people treat each other.
Yeah.
There's lots of things that people with normal jobs just don't see. And it's hard to. Yeah, I think after a while, you just sort of become hardened to it, and it affects you. It definitely affects you. I've not had the experience of like recurring dreams or anything like that. I mean, I definitely have PTSD from when my boys were born.
Yeah.
But because they were very sick and had a lot of trouble. But from a work standpoint, I don't think I've had that. But otherwise, like my experience is very similar to yours in a lot of ways.
Yeah, it's tough. And it's one of those things that you talk about going through care reviews. As I've moved into leadership roles, I really kind of view my leadership role as really like three main components. And at different times, the components are weighted differently depending on the circumstance. But it's kind of like, you have the component of your role as a leader is really patient safety, to prevent patients from being harmed, get them the best outcome for the system that you're kind of overseeing or responsible for. There's like a culture that you need to maintain of like the people that are functioning under your realm are all kind of in a safe space, so to speak. I mean, not having like an abusive department kind of situation. And then, but then thirdly, there's this aspect of like when you're like the chairman of the Department of Surgery, like I'm serving as currently, that's an elected position by surgeons. And so you're kind of representing them. And one thing that you can hear sometimes, and I'm not pointing out anything, and I'm not saying that this is my own institution or anything like that, but I think when you listen around, there is this idea sometimes that surgeons don't care, or sometimes that like some people don't react the way other people think they should to a situation, like in their interpersonal interactions. And so then there's this like major extrapolation by maybe the way the surgeon reacted in one conversation or something, an extrapolation to saying that this is how they approach it or this is how it's affected them. But just like you said, sometimes we have to harden ourselves a little bit just to get through the day, to continue to deal with like telling 30-year-old mothers of 3 that they have like stage 4 right-sided colon cancer. I mean, those types of situations are becoming much more frequent, and at least in our experience. And so, you get in these situations where if you're like letting yourself fall apart every single time something that really could justify you falling apart, if you let yourself do that, you're really going to be kind of a poorly, like it makes your functioning as a physician compromised for the next patient you're going to see. And so we have like a responsibility at some level to be able to compartmentalize that enough to maintain the quality across the spectrum of people we're expected to take care of. But other people don't see the nights that we're at home and we're like zoned out because we're focused on something, and other people don't see how it affects us behind closed doors. And so I think I got some feedback actually recently from someone who was listening to this podcast. They're not a surgeon, but they're in the medical field. And their feedback was, I never understood what surgeons go through. And I have a newfound respect for surgeons, and it's going to change the way that I interact with them. And I honestly, that was like one of the biggest compliments I've ever gotten for this, because otherwise, you talk about imposter syndrome. This podcast has been like the biggest level of imposter syndrome for me. Like people come and talk to me and I'm just like, you guys get that? I'm just like making this up, right? There's no, like, this is not some like master plan. This is completely just made up on the spot. But I think that, I do think that us having these conversations more openly, while sometimes it is uncomfortable and it's not something we're used to doing, it does have the benefit, hopefully, of being able to kind of shed some light on the fact that, man, this stuff is hard sometimes. Not saying that everybody feels the same way. I'm not saying that there aren't bad actors in every single profession, and there's definitely some surgeons that we probably all know a surgeon or two their actions would suggest that they just, they take it a little bit less personal than others. We'll say it that way, but it can be very, very tough, and it's something that can really affect a person. And so I do think that we need to do a better job of talking about it.
Absolutely. I think generally speaking, like you said, there could be, outliers, but generally speaking, surgeons are extremely dedicated to what we do, and we take what we do very, very personally and want nothing but the best outcomes for the people that we take care of. And I think, generally speaking, again, feel extremely honored and blessed to be able to do the job that we do.
Yeah, it's and it also can show up in weird ways. Like it can show up in the OR with frustration when you feel like other people aren't taking it as serious. And it has
100%.
And it has a potential, and you look at it and you're in a situation where you're going like, guys, we need to tighten up, because this is somebody relying on us to do a good job, and we can only do as good a job as the team's doing. And so if not everybody is rowing in the same direction, it can sometimes come out as frustration. And, in leadership roles, sometimes you get those complaints and things, and you kind of look into it, and you can go and kind of provide it as an opportunity to have a discussion about, hey, this is how you're being perceived. It's probably, I understand the frustration. I'm not saying that there's not, but there is a level of bridging that gap between people that aren't surgeons and are, on trying to develop that understanding. Because I think many, many times people are all people are all wanting the same thing, but they're speaking slightly different language on how to get there. And it's just that gap can be very detrimental.
Yeah. And the position that you're in, surgeon versus not, your words are perceived differently. And I didn't realize that, probably for a while, stepping into this kind of job. But you really have to be careful with what you say and how you say it, because what we say is perceived differently by different sort of levels of people that we work with, and it can things that you say that may just be you feel is very benign can be taken very, very differently by say a nurse or an anesthesiologist or someone. We definitely have to be cognizant of how we say things in addition to what we say, and just be sensitive to that kind of stuff.
And the other thing that really kind of is honestly, it's one of my pet peeves is sometimes I'm not saying that we shouldn't hold ourselves to an incredibly high standard as surgeons. I'm not suggesting that. But one of my things is whenever I feel like there is a lack of continuity or fairness amongst how everybody in the situation is being held. Like one of my biggest things that drives me crazy is watching interactions between two physicians, and one physician is deemed as like a problem physician and the other one's deemed as like really passionate about patient care. That drives me insane because I'm you sit there and you go, that insinuation, the problem is that the insinuation is that the other person, that the surgeon is the other person or whoever it might be is not. And that's not necessarily true because people have different ways of expressing themselves. And there's definitely levels of professionalism that need to be maintained. But if we're going to ask for professionalism from one side of this coin, we need to be sure that we're asking for similar professionalism from the other side. And I understand that heavy is the head that wears the crown, and that being the leader in the operating room comes with it certain expectations that are probably above and beyond the expectations of everybody else. But when you're trying to really function as a culture of a team, because I think that the old days of the paternalistic or even maternalistic view of the operating room where, this is what I'm saying is happening and nobody gets to raise any concerns and stuff, that age has for the most part passed in a lot of ways. Sometimes the pendulum swings too far the other direction where we can see there's like, if nobody's leading the ship, then the ship's just kind of going rudderless. But I think that there's definitely a balance that needs to be struck. But I do think that everybody along the line hopefully is maintaining and being held to the same standard along that, because that's one of the other things that really frustrates me, because surgeons and many times are very direct communicators. And we're direct communicators because that's what we need, right? So we don't, whenever we ask for an instrument in the operating room if someone's bleeding, we don't go, hey, when you have a chance, would you mind handing me that, that hemostat, please?
Right.
We're like, somebody's bleeding, you're like, hemostat, you put your hand out, right? Yeah. Well, if that was how we behaved when we were picking up, silverware at a restaurant, that would be a very different scenario. And I think everybody can understand that would be like a silly thing to expect in that setting. But in the operating room, under very intense settings, I just hope that the opposite is true, that everybody kind of goes like, well, yeah, people were very direct and there was not a whole lot of niceties being said, or we weren't saying please and thank you. We were just trying to get to the point, because in those situations, it was a very critical point in the case, and we needed some direct communication to make sure that there was no ambiguity that could potentially delay or lead to harm. And so it's definitely a balance between being malignant and being direct, but sometimes even being direct, if the person is not used to that culture in that situation, can be perceived differently. And that's really goes to the culture of an operating room and how it's a really weird microcosm, right? A lot of dark humor, a lot of those things that we all kind of, it's a culture in and of itself that right or wrong develops. And I think a lot of it develops around the fact that it is an incredibly stressful situation. And at some points you have to have those little vents to diffuse off some of that to reach maximum function.
So what are some things what are some strategies that you use to keep your stress to a minimum in the operating room?
At appropriate times, I joke and I keep things very light. Again, appropriate times. I also, try to know, I have the luxury of having a fairly consistent team. Not 100%, but like some people that I work with frequently, knowing them on a personal level, as far as like having a conversation, during turnover or having something like that, just getting to know them, that kind of personal relationship, so that they understand who I am as a person, so that if we are in a very intense situation and I'm having to be very direct, or things are getting tense in the operating room, that they understand that I'm not trying to be malignant. Like it's just, this requires this is very, very serious.
Right.
I think that those things are how I do it. I do little things. Like I let the staff choose the music in the room. Just things like that, because, if everybody's sitting there listening to, the only time I don't is I have this really fun joke that I do around the holidays, and I ask for Christmas death metal playlist, and they exist, and they are the
Nice.
most like intense Christmas carols you will ever hear. And I make people listen to it for significant times, or I'll go in while Bobby, my partner's operating, and I'll put, like, everybody's busy, and I'll put Aqua Barbie Girl on repeat in the operating room, and I'll just leave. I'll do that occasionally, but I do think that keeping it, knowing who you're working with, trying to keep it light when it's appropriate, so that it also helps, so that when you are serious, everybody understands that it's a serious time.
Yeah, I think the thing that you said. I mean, I'm not I don't know. I don't think I'm a big joker, but for me, the biggest thing as far as stress relief is having a solid and consistent team.
Yeah.
And to be comfortable in the OR with the people that are helping. I think that's the biggest thing for me. Like when I have a team that is, when we're doing robotics at my place, we always have a PA at the bedside. So it's like one of the standard things in our system, that we always have a physician assistant to do the bedside assisting. And when it's a PA that I'm very comfortable with, or I know very well, it's way more like when I know going into that day that I'm going to have, Tracy or Malcolm or one of the PAs that I'm really, really comfortable with. I'm going into that day way more relaxed than if I'm going in not knowing, or if I know that it's going to be like some brand new person who I'm going to have to walk through every single little thing.
Sure. Yeah.
It just makes me feel more comfortable knowing that, like, everybody in the room is on the same page, knows all the steps of the case, knows what's going to happen. I don't have to, like, because a lot of the stress is like remembering every little possible thing, like, not remembering to, like, say what kind of sutures you want. And then it comes to the time to start doing stuff and there's nothing on the field,
Right.
Whereas if the team knows you and knows what's going to happen, everything's just there, those are the kind of things that make me feel better, that I don't have to like be on top of every little thing. I think that's a huge deal. I think most surgeons are probably that way.
Massive, because what people don't understand is the level of, there's so much that the human element, there's so many steps that can go wrong during a surgery. It is an incredibly human experience, because you have so many people contributing. That Swiss cheese model of safety, you start removing a few of those sheets with people that just aren't experienced or have an issue, and then all of a sudden it's a lot thinner, and there's a lot higher chance of that. And I think we all can sense that whenever you're in the operating room, and that, and people just don't get it. They don't know what the steps of the surgery. They don't have the suture. You're in a bleeding situation. You're like, call for a clip, and then you have somebody who's like advancing the port, a millimeter at a time, because they don't understand that, like, the flashing green light gives you some ability to put that back to that location. Little stuff like that makes a big difference. And
or even just like the scrub and the circulator, like being people that very well and you can trust, and like are people that are very responsible and all that, because like even things like the count, you know what I mean, like you can I'm like very, very, very cognizant of the count and the potential for retained foreign objects and lost things and all that stuff. So I'm like, I can't. The surgeon who doesn't stop or slow down or take a second to pause when there's a discrepancy in the count, I can't understand that, because like there is such it's something that you can fix. It's something that we do purposefully to make sure that a negative outcome doesn't happen. And it's something that can cause such a big problem if it's not taken care of.
Yeah.
So I'm like a like you can, there's a scrub that or the scrub tech that works in the one of the robotic rooms that works with me a lot. Like she knows, like at the end of the case, I'm gonna ask, did I take the ruler out? Did I get all the needles? Like
Yep.
every single thing. Like I always ask her, even though I'm pretty sure I did. Like a lot of times, I will finish a case like if like this like even if it's a bigger or smaller ventral or something like that. But if it's a longer case where I did, I was measuring stuff and so I won't remember. Like
You
I have
can't.
no recollection of taking the ruler out, or of taking like the big Stratafix that I used to close the fascia. Like I don't remember taking it out whatsoever. I don't remember handing it to the PA to take it out. I don't remember it coming out.
Mm-hmm.
So it's just because I'm so focused on whatever that I can't remember it. And I'll go back and I'll watch the video and I'm like, oh yeah, I just took it out right there. But
Mm-hmm. Yep.
I can't remember it. So like I'm like very much aware of the potential for that. So, but back to the whole point, like having someone that you trust and yet makes it so much less stressful than working with people that you don't know.
And not all cases are created equal. Like if you're doing a TAR and you're putting in needle after needle after needle and stuff like that, it is such a disruption. Some people have spoken about it. I don't know that I've ever actually gotten into it. They talk about the flow state. I think Flavio was talking about flow state, and I was just, he might as well have been speaking a completely different language. I was like, wait, so there's a point in time when you're in the operating room that things seem like they're going correctly? Like that exists? I don't even know what you're talking about. But no, it's this. Yeah, I think that there are those moments where nothing can be more disruptive to kind of like your progression and you're paying attention to stuff than going like, okay, I'll take that 2O V-lock. And 2 seconds later, someone's tapping you on the shoulder and they hold up like 4 different sutures. Which one do you want? And you're like, okay, that one, and then you're like, okay, what was I doing? And you're like back to it. And we have, not all hospitals have the ability to have like dedicated teams. And we're kind of in a hybrid situation where we kind of do, but everybody needs to kind of be able to know everything because they have a craft that they're doing too. Our call teams cover a wide spectrum of cases and specialties, and they can, the people that work in our robot room, they need to be able to function for a broken femur in the middle of the night. You know what I'm saying? Like these types of things too. So I understand it. But there are different cases that have different potential for complexity, and those cases by far, it is undeniable benefit from standardized teams with more experience. And it's a tough thing because I understand the staffing concerns and some people are more demanding about it than others, but it definitely does affect your day. And at the end of the day, it affects your well-being because again, if I were with the team that I trust, I'm not, like you said, I'm not reviewing the video at 2 a.m. on my app going, okay, like as you said, did the ruler come out? I did this needle. I don't, I verbally confirm it, but I don't remember seeing it go out of the trocar. Did it go out? In all these things that you're like going back, watching these steps of these videos. And again, I will look at all the counts myself and all that stuff, but I've also served in some reviews and read things. And one of the most common things about retained foreign bodies is a correct count. And that's like probably the most terrifying thing.
You mean like the count is correct in the case where there's a retain? Yeah,
because if it's incorrect, you stop. Well, I mean, with rare exception, right? But for the most part, like if it's incorrect,
the count was always correct in those cases, or most, because if it wasn't correct, then the case wouldn't have ended.
Right.
So it had to have been correct, even though it wasn't. But yeah, the other thing with those kind of cases is it typically something about the case was not the typical,
correct,
if that makes sense.
Yeah,
it's like, something that was done was not how I typically did it or do it, or there was some variable that was like out of the ordinary, and it just sets you up for those kinds of things. So yeah, it's, it might be boring, but like, standardization of things is like, it's like really, really important to just make sure that you do it the same way every single time,
Yeah, it is. And it's harder. And again, these cases, there are definitely standardized points And then there are parts of the cases when you're doing like complex ab wall that some of that stuff is, it's on the fly. Yeah, you get in there and you go, wow, they don't have a posterior sheath. That's a completely different. That was unexpected. I put a camera in the other day and like there was just the rectus muscles were staring at me from the arcuate line down, and I was like, oh,
let me guess. It was the GYN case.
The C-section. Yeah, they didn't get the back closed. And you're like, oh, well, this is a much more complex problem than I thought it was going to be. And those situations, you have to be prepared for those. And I think also that's one of the things that when you talk about people doing these more advanced techniques, it's kind of hard in some cases to predict what you're getting into, because I do a lot of bigger inguinal hernias. And I do very thorough exams, and I would like to think I'm pretty good at it. And the number of times that I get surprised by, man, that did not match on exam what I see when I insufflate the belly versus what I felt on exam, or even sometimes if they have imaging, sometimes it could be like, whoa, that extended way deeper than I expected it to. This is a big inguinoscrotal, and so sometimes these prediction pre-op, you can get into trouble if you're not prepared for that. And I think that's where a lot of really well-meaning surgeons can get into situations that aren't great just by getting caught off guard in the operating room.
No doubt. I mean, that is one of the things about doing ab wall as a big part of your practice, or the main part of your practice, is like it's a stressful thing walking into a case not knowing what you're going to find in there. So like you could take somebody, this is the way I'd explain it to patients a lot of the times. Like, you could take somebody who's had one laparotomy for whatever and go in there and it could be like a bomb went off. Or you could take somebody who's had 10 laparotomies and go in there and they have no adhesions. Right. So like you really can't, absolutely predict it. Can, like, after a period of time of like doing this for a long time, you sort of get your own sort of gestalt of looking at this person and looking at their op reports and looking at all the information and say, I think you're going to be all right. I'm going to be able to get into your belly and do it minimally invasively or not. And then you do it open. But you definitely, there's cases where you're wrong, particularly like I when I take patients for open operations, like often than not, I'm saying to the resident that's doing with me, I could have done this robotic. You know what I mean? Like it's, but I'm never like unhappy with myself about doing it open. Number one, because doing open surgery is a lot of fun. The cases are great. The residents love them. They get a lot out of it. That anatomy. But ultimately, it's for patient. It's for the safety of the patient. If I don't think it's going to be safe to try to get into their belly, to try to get gain intraperitoneal access and develop pneumo without potential for bowel injury, I'm not gonna try. Unless I think that it's very the ability of me getting in minimally invasively is the stopping point of whether I'm going to do it open or robotic or laparoscopic minimally invasive. And if I can't justify to myself that I think it's going to be safe to do it that way, then I'm going to do it open. And I think that that's completely fine. It's very, very, it doesn't happen that often. It's like 10-1 robotic to open, or maybe 8-1 or something like that. But, that is what it is.
Yeah. It's, you're 100% right. You get, when you make the best decision with the information that you have at the time, there's nothing wrong with that. Expectation, is there a situation where you maybe years down the line, you've seen enough, you've seen this presentation enough that then all of a sudden you have a little bit better gestalt and you can predict a little bit more accurately just through the tincture of experience. And for me, I have a really hard time looking back on cases that I may have done 5 years ago or even longer, maybe 10 years ago now, and going, God, man, feeling bad about myself. And then going I didn't even that patient would have done so much better with robotics. I'm feeling bad about the decision I made. I'm I wasn't even doing robotics. It wasn't even a thing back then.
Wasn't an option back then.
Right. And it's so funny because again, perfectionism And this, like, it serves us well in so many ways, but it can also be so toxic internally for yourself whenever, like, I've said it before, but if the expectation is perfection, you never succeed. You either meet expectation or fail. And so it's just like you're always on this hamster wheel of this, like, self-reflection leading to this fulfillment of a prophecy that you're not doing well enough, because you never feel, there's never above zero. There's always just zero or below. And so you're always, like, kind of fighting it. And many times patients, they benefit from that level of, like, hypervigilance and that awareness and the double and triple checking things. Like, sometimes that can be actually beneficial. There are things that people catch that you may not have if you didn't have that level of like urgency to make sure things go well. But at other times, it's like, is it shortening your career? Is it making your learning curve for these cases longer? I mean, we talk about like efficiency in the operating room. I would love to see a study where they go over, like, okay, well, this person's learning curve and their operative times and their efficiency, early in their career, it was this number, and then it may dip a little bit as they get more comfortable. Then they may start doing more complex cases, so it worsens again. And then as they develop that better, understanding, going kind of like down the Dunning-Kruger curve, it gets better. I would love to see that paired with a surgeon's mental health, right? So you have somebody who has baseline anxiety or baseline perfectionism that is maybe higher than the average. What does it look like? How does that curve change? How do their outcomes match, right? Because that many times on those, like, curves of stuff, there's no, like, going, like, quality and complication curve running along with this, like, that's an assumption. There's an assumption made that all these cases turned out well, and so there's so much more complexity, and we don't take into account the human aspect of performance in surgeons currently near to the level that other high performing fields do. Professional sports, it's a big deal. Like, human performance, that's the whole thing, right? And they have to have a competency, they have to have a skill set, they have to have a dedication and a drive, and there's all these other factors that they have to have. But at the end of the day, if someone gets the yips, it doesn't matter. Those other things don't matter at all. And surgeons are, like, not immune to that. And we don't do a good enough job of providing. We have a really good job of working through these peer reviews and these care reviews and stuff to make sure patient safety is maintained. Again, incredibly important. The most important. But what about, like, the psychological safety of the surgeon, the getting them through that to get them back on their feet? Because you have someone here that has gone through years and years and years of training. There's been a lot of resources invested in getting this person to the level of proficiency that they can positively impact their community in the field and their patient population. And if we don't support them, we're losing. Like, we could lose significant investment, if nothing else, just from the pure, not even the human side, but just the pure economic side. You can lose significant investment because we're not focusing on it enough. And so,
we at my place, we have something for that. I don't know if you have experienced that anything at your place, but we have at Christiana, we have something called Care for the Caregiver. I don't know if you guys have something like that at your hospital, but it's actually a really nice resource, which is, if there's a negative event, if there's some kind of traumatic experience, patient dies, something bad happens, negative outcomes, traumatic something or other. They have, like, people come in, like, in person, but they also have resources that you can actually, get, some counseling and talk to somebody and sort of, like, go through it. So you don't, you work through it without sort of being alone. I just share with you I had one experience where I had a patient passed away on the table in the operating room, an elective case, on table MI, died right there. And it really, really messed me up, like, bad. And it was really difficult to get through that. And I used that. I used the counseling and I went through the sessions, and it helped a lot. I don't think you ever get over anything, something like that. I think about it all the time. But I hope most places have that kind of resource for, you know, the people that work at the institutions, because it is important to support us. Because, it's just like we've been talking about for the last hour or whatever, we are incredibly affected by our jobs, and our patients and how they do, or how they, how the outcomes are, and it can be really, really devastating when it's not good.
Yeah, we do have that resource available. We have an employee assistance resource. We have resource for like the care, for like support for all the team members, from all the way from the people that were transporting them to the people that were to the administrators that feel responsibility for the patients in their facility. So I mean, it does, and they do an absolutely tremendous job. And I have utilized those resources before. I know colleagues that have, and I've never heard anybody have I've never heard of anybody having a bad experience or a negative thing. I mean, I'm sure they exist, but at least in our situation, the people, shout out to Mary and Laura. They do just incredible work here. What I can say is, I think there's two things that are also true. One is that I think there's like this these micro complications. I think it's really easy for us to look at those situations like the one you're talking about, which is, like you said, that realistically is going to stick with you forever. And so those things are really easily identifiable when we're looking from the outside, and it's not necessarily our case to go like, hey, that person probably needs some help. It's the micro stuff where you have like those 3 or 4, like the other day I saw a patient that had a recurrent inguinal hernia. And then like the next patient I saw was having some chronic groin pain. And both of them were my cases from like a year ago. And I went home just like, frankly, just devastated. I was just like, like, what the heck? Like I looked at the imaging and I'm going like, well, there's probably what I did that made this fail. And then I'm sitting there going
it's so hard to like not tell yourself that you suck
Yeah.
in those situations. You know what I mean? Like I must be the most terrible surgeon. Why am I allowed to do this? How am I allowed to do this?
Yeah.
I shouldn't be doing this anymore because I'm not doing a good job. It's so hard to deal with those situations.
Yeah. And, so those like little micro things just from a day of clinic, like nobody from the outside is going to go like, hey man, he probably needs somebody to talk to, you know what I mean? And different people react differently. Listen, like I'm on probably one far end of the spectrum. And there are people that are very, very well adjusted and they have great perspective and all that stuff too. There's the whole scope. And so I'm not saying a one size fits all approach is the right thing, but I think there's probably room for expansion and more understanding. But realistically, you're not going to know unless the surgeon feels comfortable talking about it and reaching out for that help. And there's still so much stigma. I mean, I think we're so much kinder. I've always said that like we're way kinder to our pets at the end of their life than we are other humans in a lot of cases. And similarly, we're way kinder to our patients and give our patients a lot more grace for their own struggles in mental health and stuff like that than we ever give to ourselves or our colleagues. And it's not like we're trying to be malicious, but it's something where we really could improve upon. I've been in counseling for years. My own personal counseling. I've utilized the physician resources too for my like physician specific stuff. It's hard to separate the two many times. Like, when you're working 80 hours a week, that is kind of your life. Being a physician in many cases is your life. One of the things that I've said to many people, and I'll say it here, is some of the best sessions I've ever had were when I wasn't in a crisis. Because that's sometimes when you can have that work. If you're not trying to put out the fire, you can talk about the things that you can do to prevent the fire from happening. And so, like the cases when I'm not sitting there reeling from from something that was very triggering, like a bad patient outcome or something, that's one type of intervention. And then there's like the intervention to build that resilience to, hey, get that, to try to gain that perspective when you're not in a crisis to go, actually, maybe a good idea would be to look at my data. Maybe, not saying that any recurrence is good, but if I'm like way under the national average, then, having a recurrence is kind of expected. Like you said, it's a law of averages. Even the best people have recurrences. And if I am over the law of averages and I am above the average, well, my initial thought is I shouldn't be doing this. And that's probably not the right thing to think. Probably the right thing to think is I've got a really good skill set I just need to figure out what I need to modify to make it better so that people can have a better outcome. But that requires forgiving yourself. And that's where it gets really hard for me. And because that's the part that can be really tough. But yeah, power to you for speaking out about utilizing the resources. I think that's what it's going to take is people that are respected in the community just saying like, hey, yeah, this is tough, because otherwise people just feel alone when we are so not alone. Like, it's so many. I can tell you, I have tremendous conversations with people that never appear on this podcast. And the amount of people that are just like you and I is enormous. And and not everybody feels comfortable talking about it publicly, and I 100% respect that. Many people think that I'm clinically insane for doing it, and I can half the time it's me thinking that. But yeah, I appreciate you coming on and talking about this stuff. I think it's just incredibly important.
Yeah, no, I appreciate you having me. It's like I told you, I listened to that, your first go around with the podcast, and just everything you said, not everything, but whatever. The vast majority of the stuff that you talked about just sounded like me. You know what I mean? It's just it's very, very close. I think we're very similar in a lot of ways, and I think that's a good thing, because we take what we do very personally, and and take a lot of pride in what we do.
Yeah, I will. I'll actually take this opportunity. I'll let the people that listen at home kind of behind the curtain for a second. So I do have like my own podcast that has not been released. And in that podcast, there's an episode where I talk about my intense struggles with my own practice growth, the transitions between like residency and my attending time, and my own, like, how mental health affected that, and how I, the lessons that I learned, and the ways in retrospect after a lot of work that I feel like I could have done things better or different. And so I've actually shared that. I usually share that with most of the guests before they come on, just to kind of give them some perspective about why this podcast exists, because this is kind of a natural progression of that. But it's funny because there's been a few people have mentioned that, and I've had a couple of people be like, what are they talking about? But yeah, that's what it is. I think that there's and at some point I'll try to figure out the best way to release that wider. I just haven't necessarily figured it out yet. But yeah, no, I do appreciate you coming on. As we come to the end of an episode, I always give every guest the opportunity to give their hernia hot take. Just kind of an opinion about hernia surgery or life in general. And so this is Pete Santoro's hernia hot take.
I think, again, I appreciate you having me on. I think what I would end with is how I describe this subspecialty to people that come and observe me, and even to some patients, and that it is a labor of love. So this is a field that is a lot of times the way I describe it to other surgeons or residents is that this is a field of surgery that's very personal to patients, because the problem that they have, they can see. It's almost like plastic surgery. It's very similar to plastic surgery in a lot of ways, because their problem is visible. It's not like I have colon cancer. It's in there. I got to have it out, but I don't see it. Or I have a bad gallbladder or appendix or anything. It's just a problem that's inside. And when I have surgery, I have a couple of little incisions and it's gone. This is like a big bulge in my belly, or a big bulge in my groin, or something like that, and it's visible, and it's something that can cause me like significant problems, but also I don't like the way it looks and I want it gone. And so the field of hernia surgery is a very personal thing for patients, and it can be very complex. There's a lot of techniques and a lot of newer things that every day things are being described and invented, different techniques and things, and it's a lifetime of learning as a surgeon and as a physician, obviously. But we have to adapt. But on the other end of it is a patient who genuinely appreciates what we do, and usually can't be more, grateful for the operation that you do for them, and your skill, and all that. And so it's a very rewarding field. And I think it is because of how personal it is to the patients. Because, like I said, because of, you know, it is a physical thing that they see like abnormal with their body.
Mhm.
And I do I have surgeons come and watch for robotic surgery, and that's why a lot of times I tell them it's a labor of love. This is something that you can't be getting into doing robotic TAR because of the RVUs or because of the whatever bill.
Right.
What This is something that you have to do because you love it, and you enjoy it, and you enjoy taking care of these patients, because ultimately you can really cause major problems with these operations.
Mhm.
And if you're not careful and you don't understand the tissue planes and everything, but it's something that if you enjoy and you're passionate about it, it's really rewarding, and the patients are really, really grateful, and it's a really great field to be in.
Yeah, that's an incredible insight. It's definitely much more complex than preventing strangulation or obstruction, which I think is a way that a lot of people think about hernias, is the potential for the emergency. But we talk about it being all the time about quality of life surgery is one of the things that, some of the leaders of our field love to refer to it as. And I don't think that until you just had that hernia hot take, I don't honestly think that I had really considered the visible aspect to the patient and how much that is different than so many of our other pathologies that we take care of. So kudos for a very thought-provoking and insightful hernia hot take there.
You got it.
Well, I appreciate you coming on again. Thank you so much, sir, for your time. And this will wrap up another episode of the Hernia Gods podcast. This is your mere mortal host, Luke, signing off. Thank you so much.
Thank you.